Good afternoon. Hope you're good. Hope you're well. Hope you can hear me okay. Now, as per usual, I'm forever paranoid about this technology. It didn't just play me that video, for example. I just got the blaring audio through. But as far as I can tell, it's working. I can see my co-host, Ben Wilkins, is here and joining me for our monthly newscast. We talk about public health. And he is the man that we trust in that space, the CEO of Good Boost and good friend of the show. Ben, welcome back. And it's been an interesting month, hasn't it, for public health, with all the opening up and all the stuff that's going on, as well as the nice gardens we're going to talk about.
Yeah, it's been a really interesting one. And to give you a bit of feedback on your intro, I could have been at a rugby match right there, or an NFL one, because the music, the pyrotechnics on screen, that was, I haven't seen that before. So that was a great change. Yeah, there's been a lot going on this month, definitely.
Cool. Yeah, well, do you think that these sorts of, as the world is starting to at least attempt to normalise, the conversations such as we've been having on the newscast in recent months, they just become I feel like they become more and more relevant, because people are starting to have to re-engage with, like, what are the sort of nominally sociological interventions that do naturally overlap and should be integral to MSK, the things that you are passionate about, getting people to think that bigger picture. It feels like the conversations of pointing people in those directions and signposting them just become easier as we start to open our minds again to the world beyond Zoom, I guess.
Yeah, here's hoping. And I think there's a few milestones to get through. I mean, I know that where we work in a lot of leisure centres, they're holding back until group exercise is available. But the moment those milestones are hit in terms of reopening the country, the opportunities out there to think about integrating self-management into the community will be viable. Social prescription and signposting will truly take place again. It's just getting through to those milestones now.
Absolutely. Now, one of the things that's occurred in recent weeks is that NICE published the chronic pain guidance that's been long awaited, and we were privy to some of it because MSKR was a stakeholder group, and we'd submitted some feedback on various different things, and there's some stuff that's there that's not surprising, some stuff that is. It's been somewhat controversial in some quarters, but generally speaking, how would you describe the sort of conclusions that it's come to as if a theme?
I think as a one-word response, it's destroyed and debunked the perception that drugs are the only way to treat pain. And I think clinicians and health institutions have been very aware for a long time, but I think it's really important for people living with long-term condition and chronic pain to have that kind of out to them as well. But it can also create a lot of fear, because you've got a bunch of people who are going, are you going to take away my medication, which has become a huge part of my self-management and dependency on that. So it's been great that NICE have published this. It's been great they put some recommendations of alternative therapies, but it doesn't mean that they're easy to access for people living with chronic pain, or easy to recommend to clinicians and signpost to either.
That's one of the things that I'm sure we'll get stuck into, is that we're going to talk and unpack on this show a little bit about suggestions as to what infrastructure and things we need to implement to better support therapists and clinicians to enact some of this guidance, of which we'd be supportive of. But I wondered just your thoughts on, do you think it's NICE's job? Because some people have said, NICE, it's all well and good in saying this, but the fact that they've then stopped short of then giving suggestions or helping support the infrastructure that would be the how do we enact this, do you see that as being a failing of NICE and the guidance, or do you just see that as an inevitable consequence of these sorts of things, that it's up to us, it's up to the MSK community? Where do you stand on that?
Ooh, I do not think it's a failure on NICE and the guidance. I think a lot of the options are there, and without the pandemic happening, GP referral programs, social prescribing, everything that's going on, there are loads of community offerings now for people to do these therapies. I can see in the chat that acupuncture's been put with a huge exclamation mark, and acupuncture can now be used in certain defined guidelines for managing chronic pain. It's not just the fact that the opportunities being there, GP referral programs, all these kind of things in leisure centres in the community. It's the transition from a person living in chronic pain, not just being offering them in the community, but then taking those steps to engage and on their self-management journey. I think that's what's missed out a little bit in here. It's great that it's been put forward that it's not all about pharmaceuticals and drugs. There are these things that have the evidence behind them, escape pain, everything else is out in the community. But I feel where the gap is how we're going to support patients to truly take up these options.
Yeah, I mean, if we allow ourselves to think sort of utopian on stuff like this, and me and you have joked before about the fact that we as organizations, we quite like that idea of almost you sort of pitch for what's perfect and then we end up as pragmatists, rather than sometimes people are looking at the detail of the pragmatism and then aiming and aspiring. Whereas I think me and you like to sort of blue sky think. We've talked about that before, I think even on this show. So if you think about what that probably would look like, I think that the workforce aspect would be that if that was possible, you would have really well-trained people, and lots of them as advocates, as partners, as people helping those with these symptoms and those aspiring to these interventions to help make those correct decisions, that are also well trained in the appropriate triage and stratification of that, whereby there's some serious pathologies or other things that need to be investigated further to make sure that things can't masquerade. You know, we hear horror stories of people that have been palmed off that have got serious pathology that just also concurrently have persistent pain. We'd hate for those to get missed. So, but it also, the reason I'm describing that as utopian is we know that there's workforce and access problems with that. Do guidelines like this help us aspire in that direction, though? Like we could think of that MSK professionals, especially those in our network, of course, I'm just going to flatter our listeners and the MSK and Good Boost and Physio Matters ecosystem that we're helping to create, right? We know that those are the sorts of people we'd love to proliferate. Do you think this helps us get there, or is it something that ends up being a bit of a distraction because essentially it feels that the narrative I'm hearing a bit about when people have read about the NICE guidance is that it risks the fact that people then just look at our existent systems and then try to then just bolster those rather than support what would need to be quite radical reforms and changes in workforce. Does that make sense?
Yeah, completely. I mean, the guidelines do reference things like shared decision making, the importance of looking at every individual, how pain impacts their day-to-day activities, goal setting, and these aren't new words. They've been around for ages. I remember one of the first Physio Matters podcasts I listened to with Mike Stewart around kind of reframing pain, using metaphors as part of clinical reasoning. It's great that the guidelines have cited the importance of shared decision making. What I don't know is, from a clinician day to day who has got now an even bigger caseload to get through because of the backlog of COVID,
Sure.
how are they going to find the time to truly invest emotionally into having these conversations about shared decision making, about coaching rather than telling? You can go on all the training courses, but when you've got deadlines and KPIs to hit, it doesn't mean you're going to go and do them.
The rubber hits the road on that, doesn't it? It's like,
I think it's great.
tough.
It is blue sky thinking. The guidelines has really highlighted the role of shared decision making, the importance of really spending time to understand and set goals with people living with long-term and persistent pain. But just using a buzzword doesn't mean it's going to be implemented.
Well, no, exactly. It's something that is at risk of being all talk unless we can think of ways to do it. And I think one of the things that I get frustrated about is that there are some pockets of not even just best practice, but like beyond just, you can't imagine the examples and case studies, and some of which you've highlighted to me before across the country, where they're just doing things brilliantly. And I don't know if you saw the episode, I think it was last week, with Darren and Becky from Connect have done a public health intervention service, and they're getting some great results and stuff. And it's like, but they are silos, right? It's just, we're just deep in the postcode lottery, which we've talked about on this show with you before. But I just think that there need to be opportunities rather than just challenges. I'm not trying to just neg on it, but I'm just looking on and just thinking, like, the way in which this guidance should support a lot of what we kind of know to be best practice, but it could be such a confrontation that it might feel like too big a mountain to climb. I think it might feel quite intimidating, and the timing of it within the pandemic and the waiting list and stuff like that is that to some extent there's going to be temptations for clinicians that are facing lists of 15 to 20 patients, that the exhaustion of doing that sort of a good way of framing it, really, the coaching rather than telling model is going to be tough. And so whilst and I think that I take on that challenge, by the way, I really want to then think, what can we do? What resources can we provide? How can we use the digital education that we've been able to produce to support that. But again, the burden does seem to land squarely on clinician shoulders. So what do you see as being the key things you would advise that people start to engage with and think about with regards to, say, social prescribing or other signposting opportunities? Where do you think the biggest fish to fry are for people that want to better themselves there, but also not just pile a load of pressure on themselves as individuals and be able to actually then distribute that work and that treatment and care elsewhere in the community?
Yeah, I completely agree with you. The real challenge here is that delivery of therapy and access to therapies is patchy at community level across the country. And so this definitely needs to be addressed urgently. And if the new guidelines are going to make a genuine difference for people living with chronic pain, then we need to figure it out. I wholeheartedly believe in the principles behind social prescribing and what it can offer and what it can do. It is still patchy. It is still trying to figure out moving from a lot of social prescribing, either transitioning to digital or having to launch as digital through the pandemic and now moving into face-to-face. But what I believe it presents is the opportunity, because you have an additional health professional who key role and training has been around motivational interviews, shared decision making, understanding the community, and having that time where other clinicians in therapies and in medicine just don't have those time to have conversations. And that's where it represents something that we've never had before in terms of capacity. If that can be done effectively and it rolled out at the pace of the ambitions that is currently being put forward by the NHS and the Academy for Social Prescribing and the other institutions that are supporting it, WIS, UK Active, all those organisations, if it can be delivered alongside their ideas, their aims and ambitions, I believe it can happen. It's going to take some more time yet. I mean, I'm a massive advocate for the existing frameworks of things like leisure centres throughout the nation. There are 5,000 gyms and leisure centres, and these represent consistent venues that have staff available to offer that face-to-face support, different equipment and facilities there, with people experienced to support people with long-term health conditions. I know there are new programs to training up PTs and fitness instructors. They feel more confident working with people with pain and MSK conditions. So I think it's all there. It's just when this idealized view that I have of what can be is still 2, 3, 5 years away, and that's what we're waiting to get to. I think that's the gap between these guidelines coming out and what actually be a reality in the community.
Yeah, and that professional support and backing and integrated working for the sort of. This is what's interesting about MSK therapies, isn't it? What a perfect bridge between, say, medicine and personal trainers, medicine and lifeguards that are then wanting to pursue those sorts of understandings and stuff. And I think that's what is exciting, but also, like, I'll admit, I look at this and I think it just feels a bit daunting, considering all the challenges that we face with regards to. Also, I think there would probably be. Do you think there'll be a bit of a pushback from a medical pharmaceutical standpoint, especially with a very well-funded industry that might want to infer, don't get too carried away on this. Do you think that will come, or do you think that they're kind of probably respectful of what the harms that have been caused sometimes, especially with the epidemic?
If I'm honest, I'm not sure. I do not know the extent of the conspiracy behind Big Pharma and what lobbying powers they may pay to how heavily these new guidelines will be implemented, or actually how much they may have influenced or tried to influence these guidelines coming out. What I do believe is that the guidelines will encourage people to think differently about pain management.
Yes.
Even if we're not there yet in terms of this beautiful connected community delivery of pain therapies, MSK therapies, they will give people the confidence to start thinking differently, and that they've got a little bit of a mandate to start approaching things differently rather than just dishing out another prescription or giving another injection.
Absolutely. Now, I want to make sure that we won't duck James Morgan's point with regards to acupuncture and stuff. So I'm happy to weigh in a bit on that. But also, I want to ask anyone that's tuning in live. I know most of you, of course, watch after the fact on your commutes and the like, or visit the Spotify or Apple podcast stream, which is audio only. So please do feel free to email us info@fitnessmedicine physio-matters.com when you have any feedback, or comment on the feeds if you visit the videos afterwards. But those that are tuning in live, I always want to try to get you involved where possible, and some comments are coming in. We had some problems with the Facebook stream yesterday, but it seems to be working. But I just wondered, for those that are listening live, what's your take on the guidance if you've read them, read the summary, heard some of the headlines, including those that James has mentioned about acupuncture? But what's your take on that, as well as what me and Ben have said so far? You know, of course, we're admitting that a big net benefit of it is this idea of thinking differently about persistent pain, and also thinking less interventionally, barring the sort of big A word we'll come to in a second. But just what are your thoughts on it? How confident do you feel in actually applying it? Not just you as an individual, but your, say, teams, colleagues. How well equipped do you feel with a signposting network, or how integrated are you to those other services, to your local leisure centres, those sorts of things? So I've asked you, 10 questions there. Pick one of them and let me know if you fancy in the chat box. Acupuncture, Ben, I'm not going to get you on the hooking list. I have no idea as to your views with regards to acupuncture, although, of course, interested if you do want to weigh in. But I will admit myself that I'm someone that doesn't necessarily, sometimes people expect me to be an absolute nihilist against it, right? I'm someone that did actually train in acupuncture and used it for quite a lot, actually, for the first 6 months of it being a new skill in the toolbox type thing, right? But don't anymore. I can't think of the last time I used it. However, I'm not completely averse to it for this reason. I think one of the things that's kind of typically irritated me about it as an intervention is when it's inferred to be a very specific intervention, right? When it's inferred to be something that, especially the sort of dry needling brigade, that are inferring tissue-related physiological challenges that really you could retrofit my critique of specific manual therapy into that, right? This inference that you're changing tissue characteristics as if that's the key relevant variable to someone's symptoms bothers me. But when it comes to putting acupuncture needles into someone and it eliciting in some people a quite interesting neurological response, I think one of the reasons, by the way, I'm admitting that this is something that I therefore hold a bit of a candle for, is I am someone that does seem to, my body responds in a really interesting way to acupuncture needles. And it's something that, despite my natural skepticism, it's something that, if that's a placebo, it's a hell of a powerful one in a skeptic, right? I don't seem to be primed for it to work like that. But fundamentally, I get some weird-ass responses, including sometimes a potent pain relief that can occur. And therefore, I don't, like some do, become a nihilist to say that it hasn't got any place whatsoever. Now, that comes with all the caveats. You think, well, if I think that, why do I seldom use it? That's where it becomes quite complex, and that's a podcast in and of itself. But just to admit, for me, I don't, like some seem to have been triggered by that word, right? Just up in arms about the fact that would ever be mentioned. I don't have that response. But similarly, if it was front and center of the guidance and inferring that is the route out of pharmaceutical intervention solely, I'd be pretty outraged. But that's not what I've read into these guidelines, right? I think it's something that has been mentioned. Yes, it might piss some people off, but I think that we should have a more mature conversation that seems to be being had, whereby you've got your advocates then doing a merry dance, and you've got your people that want it to be a word that they never hear again up in arms. I'd rather somewhere in between, and that's my position. And maybe if there's an interest for it, we can talk more about that on other shows. As I said, Ben, you feel free to opt out if you want, but I just wondered if you have a take on acupuncture.
I think acupuncture has a real value particularly to the individuals who they feel it helps them. I think that's the important thing. I have a similar viewpoint around things like mindfulness. I think mindfulness too is too often thrown around as the panacea for almost everything. And actually, for certain people, it will be really effective. For some people, yes, it is their personal panacea, but actually, it doesn't mean it's the one-stop shop to cure everything in terms of mental health. And I think, rightly as you put, if it was just acupuncture being put forward, I think I have more reservations. But 5, 7, 10 years ago, I used to be very hot on debating anything that came through like this, where I didn't feel there was a sufficient evidence space to support it. And I remember having loads of arguments with colleagues and tutors and professors and everything else in between. I've definitely calmed down a lot now. I think where the most important thing for me is having choice and optionality. Right. And ultimately, for some people, it would just be aromatherapy, which is the most effective thing, just smelling different things. From an emotional, sensory point of view, is what calms them down and actually manage their pain. Fine, go for it. Fully support that. Mice may never back it because there may be a lacking of evidence there, but ultimately, where we can have choice and options for people to choose something that they feel works for them, that's a positive step forward within therapies.
And I think that that's what's interesting, is that the mechanism of effect, the inference on a mechanism of effect, is something that we end up being quite passionate about. And so if there was a suggestion, if in the NICE guidelines it says, well, one of the most important things for people with persistent pains is their chakra and their chi flow is well off, and that unless we redress that, then no wonder we're struggling with these opioids, right? You're not getting me and Ben nodding along to that. But similarly, what we're actually describing is something that the policy conversations about how that is appropriately funded or not within the health system is something that NICE often weigh in on. And I think that's where people get a bit twitchy. And I'm well up for that discussion, right? What is the threshold of quality evidence that means that it should then be tax funded on MSK pathology or on or chronic pain presentations? That's an interesting discussion that we probably can't do justice right now. But you know, I'd encourage any of our listeners who are into the discussion, into the debate, to not get carried away on either thing, right? Just check yourself against what you would react like if NICE guidelines happen to promote your favorite thing, and hold, you know, try and see every intervention through the same appropriate filter. That's kind of what I'd like to say. Faye Stones has made a really lovely point here, and I've heard this a bit this week. I think it's always good when NICE guidance catches up with us. It does feel a little bit like that, Faye, doesn't it, with regards to, I'd say less so acupuncture, admittedly, but I mean like what we've been talking about in terms of our, you know, trying to deprescribe and recognizing that there's more to this than drugs is exactly what Ben's described as being the sort of one of the key takeaways. And that definitely feels like a vindication for those in the active therapies game, as we often are. And so I really love that point. Joe Turner has said, maybe we also need to shift our mindset a little around coaching model being harder. What do you think of that then? Because we have both done that today, haven't we, Ben? We've kind of inferred and implied that it is harder. And I'd admit that myself, really, is that I find that to be harder to deliver. Do you think that maybe we're making a mistake there and probably scaring people away from learning in that direction?
Yeah, I remember talking about this at the last Therapy Live event at the Women's Health event, talking about how do we encourage grassroots opportunities for pregnant women or women to be more active. And it's telling people just doesn't work. And I keep going on, like telling people exercise is good for them is not going to be the thing that gets them to be active, in the way that just telling people that alcohol and smoking and drugs is bad for them is not going to get them to stop doing the things. So I agree with Joe that it's not harder. I think it's a shift in conversational style for clinicians and therapists out there. That it's not something we do in every day, and actually it isn't any harder in terms of the time investment. So the change would be speaking to a patient in front of you to ask them, do you think that physical activity could be good for your knee, whatever the condition is? They respond, and they probably will say, yeah, I think it probably could be beneficial. And you go, well, what kind of activities do you think would be good for your knee then? They might say walking, swimming, whatever else, cycling. So how do you think you could possibly maybe start at 10 minutes of that? What would be your way to approach that? And they could go on this, but this is the difference. It's a lot more questioning and coaching rather than saying, you've got an EOA, do you know what, walking and cycling is really good for you. You need to get on your bike for 10 minutes a day. It's the same outcome, but and same time and investment in the number of words used, but just posed in a slightly different way. And the likelihood of that person taking it on as their internal locus of control and enacting on it is so much greater result, but no harder in terms from the clinician's point. It's just a shift in mindset of how we have this conversation.
Yeah, that's a really interesting point, and definitely one that I need to reflect hard on, to try and recognize that just because existing models have sometimes meant that it's felt like that burden does land too squarely on the clinician. If we train our own and grow our own, and they kind of emerge into a world in which that is the norm, rather than something that has had to be then a reformation of their own practice, then that will be easier, because it could require less energy than more, and doesn't necessarily overwhelm, but it is a shift in mindset, and it's a really interesting point. So thanks Joe for that. I think one of the things that what you've just described highlights to me is how that style of intervention is made a lot easier, in my opinion, from being able to follow that conversation up with, I don't know if you've heard that the local leisure centre is currently working with Good Boost, or that, and I'm not just doing a cheesy product placement on our shared passions, but I'm just meaning that also you could retrofit me saying, I don't know if you've seen the new bike and trike group
Yeah,
actually works locally and then that's for people with persistent pain as well, or that there's some sort of demographic specificity that can really relate and resonate with people, that they know that they're not otherwise just going to get lapped with lycra-clad cyclists, right? They feel like actually it's something that is at entry-level access, beginners, that sort of stuff. But it is just it's an easier conversation when there is an appropriate outcome to say, this isn't something that you only have to self-serve, or between the two of us, we're going to need to self-serve, that there is actually a community scheme of which we can move people into. I admit, do you think I'm sometimes overplaying that? And until we've got that in place, then tough shit, Jack? I don't know.
No, but the thing, it also could be a huge problem. So I'm a trustee of a health watch in South West London, and one of the challenges that we had last couple of years around mental health is that there's some great challenges in certain enterprises offering mental health support in the borough, and that clinicians knew about it. I'm just going, here's where we need to go. I have either finite appointment, time, and resources, but this is a great community organisation. The challenge then is the referral and signposting were huge. Their waiting list became gargantuan, and ultimately they weren't receiving any additional funding for a much higher caseload of people they were supporting in the community. So the challenge is not just having an option to refer into, but having sufficient options with enough capacity where those options are also well funded, hopefully, by some sort of health budget to make sure they can pick up. But it gets even more complex, because in order for them to get that budget, they need to demonstrate impact, they need to measure their outcomes, so they can go back to the PCN or CCG to say, this is why we're justified, we should be receiving some income. It's not just a case of pushing the problem out in the community and expecting that third sector organisations can just pick up and provide those services.
Yeah, I know. And I think what you've just described there is such a... Your clinicians don't just need to signpost, they need to understand thoroughly what it is that they're moving people to, and appropriately believe in it, right? It's like one of the mistakes that's been made with the sort of rep scheme or exercise intervention scheme in local gyms is sometimes it's been like a therapists and have been, and understand why, because of the time pressures we've described, but they've kind of saw that as an exit strategy, a discharge strategy, rather than it being something that they truly believe in, that intervention being the best thing for that patient, rather than it being like, I'm out of time. Right, I still think that me and you and interventional care is still what would be optimal, but we can't do that for another 5 sessions. Therefore, go and see plan B, because I'm out of time, I'm out of choices. That mindset's massively relevant to how that's instilled in that patient's understanding of it, and therefore their compliance, their comprehension, their engagement with that service, as well as the fact that that sometimes ends up being a dumping ground. And that waiting list is where people don't necessarily do. And it's not; these aren't easy things to solve. But what else do we prioritize if not that? Like what? It's all rhetoric otherwise, isn't it? Right? All of the stuff that we're coming to realize, you rarely find people now that like, I am actively against social prescribing, right? Or these community things that Jack and Bennett and others are talking about. No, I think that they're not all they're cracked up to be. I just don't think you find those people so much these days. I mean, unfortunately, at least publicly, we know that they're there sometimes stalling us all on the boards of some places. But generally speaking, people know that this is the next frontier, really, is a better integration of health and leisure. But we don't necessarily doing is the next bit, right? We've got to stop talking and start doing. And obviously, the schemes, including your own, are ones of which I massively support. Louise Huntley's is seemingly to reiterate some of what we've just described there. But what would you therefore say, Ben, if you could, with your expertise in this, as to, say, Louise or others are then wanting to see more collaboration with local leisure centres? What are your top tips? Is it literally just go and get an audience with said local leisure centre manager, especially right now, or do you think that things need to be a bit more calculated than that? What's your best tips?
No, and actually, I've engaged with a lot of the large leisure operators in the UK, and they are looking for those collaboration relationships. So there is no harm at all in reaching out. What I would, though, where possible, is make sure you're doing that as a consortium rather than individual practices and departments, where you can go together as a collective to have those conversations. Otherwise, a legislator is having loads of conversations at the same time, trying to solve the same problem. So go in as a consortium or collective in your local area, so it's all lined up and it's all aligned, rather than lots of conversations and lots of signposting referral pathways. That would be the dream. But reach out to your social prescribers. Look at the GP consortiums who may already have those relationships. That would be the way forward. But they are looking for how the legislators can integrate into the local health system.
Yeah, that's brilliant, and that's definitely what I want to hear. It's one of the things that, as well, those that are in, say, private practice and are somewhat feeling like they're in a business-related silo where they feel, you know, these are the sorts of things that I would really encourage you to pick up the phone to your local other providers that sometimes, in some degree, yep, someone sprains their ankle on the high street, of which there's 3 practices. Granted, you're competing for that business sometimes. I get it. I'm not naive enough to think that. But fundamentally, when it comes to these sorts of things and the stakes being high with regards to serving your local community's health needs, then if you imagine that the 3 practices I'm describing were able to get together to at least have an audience with said local leisure centre to make sure that there wasn't any sort of accidental exclusivity that occurred, that means that, you know, those aren't good business practices anyway, and therefore you just want to get together and collaborate and recognise that that might be the way to do it, and the way to unlock better healthcare for that area, of which often these therapists, they're living in that area, they're paying council tax in that area. You know, that's the sort of way in which we can start to have a communitarian approach to these things. Easier said than done, granted, but that's where you hold my feet to the fire, trying to make sure we come up with ideas and resources and pool our community to better serve that. And it's exactly what this show's about, and why Ben joins me on a monthly basis to talk through these things and give them appropriate, specific airtime, because we talk about them generally, but sometimes we need that pinpoint accuracy, of which you're able to bring. So thanks as ever, mate, for joining me. Really appreciate it. And I look forward to next month already.
Cheers, Jack.
Speak soon, mate. Bye-bye.